some details and maybe some differentiation regarding disease states of thoracic disc disease. Several of these disease states are described here, and I've used abbreviations which I'll continue to use in the next several slides as we look at some of the imaging associated with this. TDH will be referred to for just a simple thoracic disc herniation, and that will be differentiated from TDHO with ossification of that thoracic disc. There are additionally TDH with posterior bony avulsions, and also TDH with posterior vertebral osteophytes. So I'll kind of show some pictures that were included in the article to help differentiate those two. And those thoracic disc herniations will then be compared to giant thoracic osteophytes, or GTOs, and CDHs, where that thoracic disc has then become calcific. So the article really seeks to differentiate some of these things. So here are some illustrative examples. So the TDH would be the lower left images, where you can see at the T10-11 level, the MRI shows that disc herniation, but the CT scan shows no calcific disease at that level, no posterior bony osteophytes. TDHO, they've differentiated with an ossification of that disc, which will also be compared to a calcific disc later on. The next two are the thoracic disc herniation with the posterior bony avulsions, which you can sort of see in that illustration labeled A here at the posterior aspect of the disc herniation, and the posterior aspect of the the vertebral body as well. And then the posterior vertebral osteophytes can be seen in the right image there, impinging on the spinal cord. The giant thoracic osteophytes can be seen in this pretty impressive left lower image here. And then finally, the calcific disc herniation can be seen on the lower right. So the whole hypothesis and purpose of this paper was to attempt to differentiate types of thoracic disc disease contributing to myelopathy, and supposing that each may have a different natural history, a different pathogenesis, and different clinical features that may assist in diagnosis and treatment. The methods of this paper were a retrospective single-center study from 2006 to 2019 patients with thoracic myelopathy. They excluded patients with diffuse idiopathic skeletal hyperplasia, scoliosis, thoracic kyphosis, which they basically just describe but don't define specifically, patients with compression fractures, spinal infection. What they examined was the type of disease by classifying it, the ventral occupying rate, and a cross-sectional image of the actual spinal canal, the modified JOA score, and the clinical features associated with these different disc disease states. They found 257 patients to include, and of patients needing surgery, they represent a relatively small portion of their overall population, 0.5% of total spine surgery, and only 8% of those receiving thoracic spine surgery. So a relatively small number of these thoracic discs. The predominance is definitely tilted towards the male, their male patients, and the average age and pre-operative duration of symptoms are listed here. About 50% of the patients described a worsening of their symptoms relative to the onset, that fourth line there. A relatively busy slide, but one of the main purposes of the paper was to describe these pre-operative signs and symptoms for these thoracic discs. Many presented with middle back pain, but as you can see, only 25% had that as a chief complaint. The additional findings that they noticed were primarily lower limb numbness or lower limb symptoms. Weakness and subjective measures are also listed at about 3/4 of their patients. Unsteady gait was found in about 50% on review. Sphincter dysfunction, 36%, relatively high percentage. And I thought it was interesting that they included several physical exam findings of patellar hyperreflexia or Achilles hyperreflexia, relatively lower numbers. This graph essentially is trying to show where in the spine, in the thoracic spine, these disease states existed. You can see the large predominance in the lower thoracic spine near the thoracolumbar junction for all of these disease states. However, they do note several, kind of in the upper thoracic and mid-thoracic areas, including for thoracic disc herniations and calcific disc herniations. So in classifying the types, they did have two spine surgeons classify these types, and they had an extremely high intra and inter-observer reliability, suggesting that their classification schemes were quite robust. The kind of meat of this paper describes the clinical features by the type, and they did have several comparisons listed. So they noted that the TDH with the posterior bony avulsions were usually younger with a stronger male predilection than even their overall cohorts, with higher MJOA scores. They noted that the TDH patients alone were usually older. They noticed also that the TDH had a lower ventral occupying rate than the remainder of their cohorts. And they also noted that the calcific disc herniations had a higher ventral occupying rate. The strengths and weaknesses of this paper, I thought, were several. The strengths, obviously, is that it's a very large group of patients with a relatively rare disease. Their goal was to describe the differences in the clinical features and of different pathology, which I think could be very helpful in trying to understand the natural history and being able to counsel patients on what the outcomes might be. They also found a high inter-observer correlation of their classification. On the weakness side, it may be difficult to differentiate between several of these disease states. They obviously describe and give these great examples, but I think, in applying that to clinical practice, it may be more challenging to kind of differentiate some of these disease states. The outcomes, I thought, would have been interesting to note from these patients. Would a patient who underwent surgery for a calcific disc herniation be demonstrably different than, say, a patient with a simple thoracic disc herniation? I thought that would be an interesting follow-on and potentially a separate study, of course. So in conclusion, thoracic myelopathy is a rare male-predominant, usually atraumatic onset disease state that occurs between ages 30 and 70, usually. The presenting symptom is very often in the legs, not always with back pain. The disease is usually found in the lower thoracic area, and the clinical features, as they've described here, can be different in different types of disc pathology. And at that, I would open up to discussion, questions, comments.
Yeah, nice review, Ben. I think I kind of like this paper because it does a good job kind of trying to divide them into sort of subcategories and groups, especially something that we see so uncommonly. I guess questions for the panelists. Dr. Nasser, do you have any specific classifications or ways that you think about these disc herniations in broad groups? And if so, does it sort of define how you approach the problem?
It's a good question. I mean, I honestly don't abide by a specific classification system, nor was I aware, to be honest, that there were classification systems for these. But I think the big distinction in my mind is it ossified or is it not? And those, I think, can be treated significantly differently. I've shifted away from the transthoracic approach, although I was doing that earlier in my career for a lot of patients that have calcified discs and now try to do them through posterior approaches. But I do think that the non-calcified discs are still a great option for a transthoracic or minimally invasive type approach, because you can actually resect those without much morbidity through an anterior approach. So I guess my biggest distinction for me is going to be, is it ossified? Is this kind of an OPLL equivalent type phenomena, or is this a calcified disc versus is it a soft disc that may have been related to trauma or just degenerative change?
Great. And I guess sort of segueing, Dr. Courier, in terms, one of the things they brought up in the article was the atypical presentation of thoracic myelopathy and thoracic disc disorders. Are there any specific findings you found that can kind of clue you in, or anything you look for in particular when you're seeing patients?
Sure. So I don't pretend to have a huge experience in thoracic discs. I don't think many people do. When I was a fellow, I had a chance to write up Frank Eismont's experience of transthoracic discectomy and fusion. And at the time, that was the largest series in the literature, and it was only 19 patients. But to your point, Ben had mentioned the long differential that you need to think about. A lot of these thoracic disc herniations, of course, on MRI scan are asymptomatic. And that study was done quite some time ago. And we see 40% or so of people will have some abnormality on their MRI scan. And some of them are pretty impressive, but they have no symptoms attributable to that. And so it's really important to go through that long differential. In that paper that I wrote with Frank, of the 19 patients, 2 of them turned out that had surgery, 2 of them turned out to have MS. And so be thinking about that. In terms of classification, I think just like Dr. Nasser said, is it calcified or is it ossified? And sometimes that's not all that clear. A calcified disc oftentimes has the consistency of sort of gritty toothpaste, and it's pretty easy to get out, whereas an ossified one is not so easy. And it's maybe others on the panel have a really clear way of distinguishing between those two circumstances, but I think you sort of plan for the worst and are pleasantly surprised when it's that nice gritty toothpaste consistency. So the other thing in terms of classification I think is important in terms of the approach is whether this is a big central herniation or if it's more lateral. And, that clearly will help determine the approach.
Arjun, this is Jens.
Hey, how are you doing, Dr. Chapman?
Good morning, Mayo Clinic, and our by now over 100 people around the world. So thank you so much for this topic. This is a great topic. And I want to second what Dr. Courier just said, picking up the clinical details, being mindful of the eternal misdiagnosis of transverse myelitis, Guillain-Barré syndrome, and MS, et cetera, is a huge deal. And we have a lot of these patients misdiagnosed. So, and I completely agree with Dr. Nasser. The main differentiation really remains with, is this a rigid calcific process or is this a soft tissue process? Now, I want to harp on my 2 big gripes about this paper, and I appreciate the effort of the authors in bringing this up. Number one, for classifications, after about 3 categories, usually the reliability of these systems breaks down pretty rapidly. What I completely missed is OPLL, for instance, or ossifying inflammatory arthropathies versus other ones. They have very different biodynamics of their cord physiology. And so that was something that I kind of missed in that. I totally agree with many of the other categories, but it was a little bit too complex for me, and it didn't address some of the very major things that at least here in the Pacific Northwest, we do see a fair bit of, i.e. thoracic OPLL. The second thing is a more glaring gap for me in the literature, which is where I'm looking at the young generation, all those bright young minds, and that is myelopathy. As you showed in that graph, most of these are in the lower thoracic cord, and both the MJOA and the Asia score completely omit one of the main problems of those patients that subjectively hits them most, which is bowel and bladder control and sexual dysfunction. And for whatever reasons, prudishness or difficulty in assessment, they're completely not thought of. And this is especially in the lower thoracic cord, a really big clinical deal. So I look for this young generation of bright minds to kind of take us past this prudishness and enhance our current classification systems accordingly. Thank you.
Yeah, all great points, Dr. Chapman. And I think to keep us on track, I think maybe we'll segue into our second article here, which Dr. Streufert will be presenting. I think there's been a couple mentions of the transthoracic approach, and I think this is a classic one. And so I'll let Dr. Streufert take us away.
All right. So the second article that I'll be presenting this morning is the anterior excision of herniated thoracic discs, Dr. Bohlman and Zdebelick paper from a few decades ago. So again, the background is a very similar background to our previous paper on thoracic disc herniation causing myelopathy. I think has been stressed already. The varied presentation of these patients makes it exceptionally challenging to not only diagnose but treat. The back pain versus chest wall pain versus ataxia, there are multiple different organ and body systems have to be not only elicited on history, but then verified on physical exam to kind of rule out these classic mimickers, whether it's a tumor, a demyelinating disease, sort of lung or chest complaints, costochondritis and mechanical chest wall pain. And then, historically, this confirmatory diagnosis can be quite challenging as well, where before the advent of cross-sectional imaging via the CT and MRIs that are so commonplace today, myelogram and myelography was the diagnostic aid of choice, sort of confirming physical exam findings. And I have a couple of the images from the paper here to kind of highlight some of the difficulties that certainly occurred when trying to diagnose these issues. The methods for this paper is a retrospective review of 1972 to patients seen in 1972 to 1984. And as Dr. Currier highlighted with his work with Dr. Eismont, relatively small series of 19 patients with 22 thoracic discs. But again, this represents a very large series, certainly of a very rare phenomenon. These 19 patients had 22 levels of thoracic disc herniation that you can see on the graph to the right. Again, predominant in the lower thoracic spine, but certainly some in the T4 to T7 region. Their presentation, which I'll highlight in the next slide as well, they did have several with back pain, but most had lower extremity weakness, gait problems, bowel and bladder problems, and spasticity. Their follow-up for these patients was ranged from 2 to 10 years with an average of 4 years, so quite a nice series of follow-up. The preoperative symptoms, as I alluded to, there is a predominance for lower extremity issues. You can see that pain in the back actually represents about 2/3 of their patients, and 1/3 had no pain in the back at all. And some, interestingly, had radicular pain across the chest. Dysfunction in bowel and bladder and disturbance in gait were also well represented in their preoperative symptoms. The diagnostics are highlighted here, and I don't know that I've actually seen a lateral cassette, a long cassette myelogram used in clinical practice, but I thought it was a really interesting presentation in this article. They used the long cassette myelogram here to identify a disc herniation at levels thoracic 8 and 9. They also describe, sort of marking the skin or using a lead marker to help identify at the time of surgery, which can be a very challenging thing to do intraoperatively to verify kind of what levels the disc herniation was at the time of the myelogram. Then the rightmost image kind of highlights the benefits of cross-sectional imaging, which can certainly help identify an asymmetric disc herniation, which would be impossible to see on just the lateral myelogram. So the advent of cross-sectional imaging could help identify the approach to take for some of these more asymmetric disc bulges. And this is obviously before the advent of MRI in about 1984. One of the highlights of this paper, and certainly being able to read it from a learning perspective, was the actual description and illustrations of the operative technique. Many of these patients underwent a transthoracic approach in 8 patients in this series in the lateral position. They additionally did a costotransversectomy in the remaining patients to address this thoracic disc disease. He performed the transthoracic approach, for when the patient was on their right side, from levels T3 through 10, again concerned for great vessels, and then on the left for T11 to L1 to avoid the encroaching liver. The approach is the approach is over the rib of the inferior vertebra. So for a T8-9 disc herniation, they would follow the level of the 9th rib, which would then be resected at its base. And I have a couple more pictures of their beautiful illustrations here to kind of describe their technique. They've reflected the parietal pleura and ligated the segmental vertebral vessels here. Okay, there we go. So, advanced one too many. Okay, so after the resection of the rib and reflection of those segmental vessels, you can follow the neurovascular bundle to identify the pedicle, and the inferior pedicle is then resected to access the disc space more fully in the spinal canal. The superior pedicle can also be partially removed if needed for visualization purposes. Sorry, there's just a bit of a lag there. So the next steps that are described in their operative technique are actually to leave the posterior sort of offending structures and disc herniation intact for the time being, and then to carve out a cavity with the use of rongeurs as well as a high-speed diamond-tipped burr to create a cavity for then decompression to proceed. The remainder of the decompression occurs by pushing the offending disc herniation and osteophytes into the cavity that was created, which you can see in the upper rightmost image by the use of curettes, whereby there is no manipulation of the spinal cord at that time to prevent catastrophic neurologic injury. So operative pearls, a wake-up test had been previously promoted, but with the advent of neuromonitoring, that gave surgeons a real-time look at the actual neural axis and neural functioning. So neuromonitoring was recommended, but was not available for all of their patients. They also looked at whether arthrodesis was necessary, and they said they did not advocate routinely for arthrodesis unless there was significant bony resection. They thought that the rib cage had added stability and fused only 7 of 19 of their patients. The length of stay in the hospital I thought was interesting at 10 days. Looking at the results, they graded the results based on this grading scheme with excellent to with normal neurologic function, no pain, good. We had mild weakness with mild pain, fair with at least 1 grade of motor improvement, but daily pain, and poor with a worse neurologic or motor exam. They found 10 excellent, 6 good, 1 fair, and 2 poor outcomes. Highlighting their complications, I thought, was one of the more interesting points in this paper as well. They had 2 complications which they described in a little more detail. They had a 51-year-old female with transient paraparesis, which did recover over the course of 6 months. They attributed this to scoliosis in the thoracic spine that increased on bending of the bed to actually achieve their exposure, which they thought increased the amount of scoliosis that was in place. They had no neuromonitoring available during this procedure. So it was a little bit earlier in their series. They additionally highlight one of the difficulties of thoracic spine surgery, where they found a 73-year-old female with worsened lower extremity weakness postoperatively. They attributed this to the wrong level being operated on after their initial myelogram was mislabeled. Preoperatively, she had lower extremity weakness, and therefore they were unable to monitor using neural monitoring. They found that she was weaker than previous immediately postoperatively and identified that the wrong level of surgery had been performed. After the reoperation, they found second operation, excuse me, they found an improved motor exam, which actually did improve over the course of her postoperative rehabilitation. Strengths and weaknesses of this paper. Obviously, it's a beautifully detailed description of the anterior approach, and I thought extremely important learning points from their complications. And it was a great description of an early alternative to a simple laminectomy from a posterior approach. Weaknesses, it was a relatively small series, but a rare condition, certainly. Changes in technology as well as neuromonitoring and MRI use in the routine setting may mean that different techniques are more available and more appropriate at this point. However, certainly this is a retrospective kind of look and one of the classic articles. In conclusion, thoracic disc herniation is a varied presentation, challenging diagnosis, and challenging treatment, as evidenced by some of the giants in the field. Anterior approaches and costotransversectomies may provide safe alternatives, but certainly they're not without risk, as described.
Great, thanks, Ben. Great summary. Obviously, this is an older article, but I think a classic one, and a lot of great images, as all those old JBJS articles have, describing the technique. I did see a couple of mentions in the chats about endoscopic surgery for this. I don't have a lot of knowledge or proficiency, so I'd open up to the panel to see if anybody had any thoughts on endoscopic approach.
Fortunately, we have Dr. Johnson. Patrick, is that you under that mustache?
Yes, it is.
Is that a glue on? Is that a stick on?
No, it's not the old me. It's the real me. It's back. Good to talk to you, Jens, and everybody else. Rod, I see you there. Great conference. You guys do a great job as always.
So endoscopic thoracic decompression. So nobody wants to slash open the rib cage anymore. It's a very painful procedure. It leads to wrong level surgery. If you have a syringopleural fistula, patients have gotten very sick, even died from that. So what's the state of advancement in terms of doing this endoscopically?
Well, I'm happy to talk, and I won't take up the platform here too long, as I usually do, or I often do, but we just published actually my paper of 19 years of endoscopic cases, and also looked at some open cases. So, you know, when we have myelopathic patients that need to be done from a front side, just from trajectory, and they're myelopathic, we do as many as we can endoscopically. I think the paper had something like 162 patients, so you can do the math over 20 years. It's uncommon, you know, about 7-8 a year or something like that. But we do as many as we can with the endoscope. Lower thoracic levels, I tend to do with a mini open, and basically do the operation where you create an excavation underneath the spinal cord. And we almost never fuse anybody because very few of these patients actually have back pain. They all present with gait problems and myelopathy. And we use the endoscope. In fact, we'll do vertebrectomies for OPLL and things like that. We've had some CSF issues, but you know, you can manage the CSF issues. And we talked about that in a previous conference that you guys had about thoracic disc problems. But I was a early guy using endoscopy way back in the mid 90s and learned how to do it with Curtis Dickman and Dan Rosenthal from Germany. And we still do it. In fact, now we've, the whole paper that we wrote is about using image guidance, and the navigation has really been a game changer, is that we know where we are, what we can do. We never do a wrong level. And we're basically doing the same operation with an endoscope as we would with an open thoracotomy. It's just that you have the triangulation of the endoscopic ports, and you have to be, you know, facile with doing endoscopy. And I know the orthopedic guys, you know, that tends to come a little more natural with them because of the training using scopes and things like that. But you know, lower thoracic ones, just because of the diaphragm and liver and, you know, and diaphragm being a difficulty, and they tend to be in older people. We do those with mini open operations and do it through a microscope and the same thing. And I just like doing them from the front side when that seems to be the most logical reason, because of the patient's pathology. Long answer, but.
Pat, no, that was great. Pat, how many did it take you before you felt comfortable? Because, you know, one of the panelists had asked the question, you know, how come it's not used more?
It's a big dog and pony show to do these cases, and I've just been comfortable over the years, and I can see where they would be a big challenge to somebody who's never been trained. You have to have training to do these things, or you have to have learned from the very beginning, is kind of what it amounts to with my practice. And all our fellows actually get to do the operations now with navigation. And so if they do 2 or 3 of them during their fellowship year, I think they would be comfortable doing them. It's not like one of these, you go to some weekend course and do it. You cannot do it. I would recommend that somebody do them open, mini open, and I mean incisions. I call them boutique thoracotomies, you know, 4, 5, 6 inches, and you do it directly perpendicular to the level. You got to have that trajectory so you can do it. Because if you do them open, you can do them endoscopically, and then you do the smaller ones. And so it takes a few. And some of my fellows have expressed interest in doing it, but not many of them actually do it. You know, out of all the fellows, you know, very few of them really do it. So it's a big learning curve, and you have to want to do them. And to me, it's actually easier now that we do them with regularity. I hope that answers your question, Rick.
No, it did. Thank you, Pat.
I think one of the things that this article brought up, and a couple of the panelists have mentioned, is wrong level surgery. Certainly the big concern here. I've started routinely getting a gold bead placed if it's, you know, mid-thoracic, where it's going to be difficult. Dr. Nasser, any things that you do to sort of hopefully avoid wrong level surgery?
I agree. We've got the luxury of a really great neuroradiology group that helps us out, and at the time of doing their imaging, a lot of the times we'll ask them to place a gold bead, and that's been kind of my go-to, especially in the mid-thoracic spine where it's a little bit more challenging to image. And I think that's what I've been using routinely. Otherwise, counting ribs and then recounting, obviously from top or bottom, is incredibly important. But I can't overemphasize how stressful that portion of the case is, just making sure that you've got the right level.
If I could just add something, Arjun, too. In the paper that Ben described from Henry Bohlman, they put a little marker on the skin. I'd caution you not to do that, because obviously that can change, and that's a good way to get into trouble, I think. The image guidance in O-arm spin is great if it's a calcified disc, but you may not be able to see a soft disc on that. And so those are really good cases for that fiducial screw actually in the bone. And another thing that is helpful, or could be helpful, maybe it's out there right now, but Level Check is a software program that was developed at Hopkins. Do you folks, does anyone have that? Is that clinically available yet? maybe that's still to come, but it's been in development for a number of years, and it looks like it's going to be a really helpful means of identifying the correct level in all cases.
So actually, current day technology, this is a great thing when I look into that, Brad. But an O-arm, or I'm mentioning a product name here, so I apologize, or a Zeem intraoperative 3D can actually work very well. And my partner here, Dr. O, has tagged patients preoperatively with a CT scan with a small gold pellet into the pedicle, and he's found that, and he's published on that to be very helpful. So there's some current day technologies that can kind of really help, right?
Yeah, I mean, I think we've also done where they get a gold fiducial placed and then a CT myelogram afterwards to confirm the placement and the level. Because believe it or not, even the radiologist can get the wrong level. And so I think it's important to confirm. We've had numerous cases. In fact, we just published our results in spine, and it's good to get a CT myelogram after the placement of the fiducial, because sometimes you can be 1 or 2 levels off.
So Jens, I want to chime back in about intraoperative CT scanning is that even with soft disc herniations, you can usually see soft disc herniations. Most of the myelopathic patients have some calcification, even if they have a little nubbin of calcium in the annulus, that would be sufficient. I would say that almost 98, 99% of the time, the intraoperative CT scanner simply nails the localization and eliminates all of these issues in my view and experience. You know, we put the patients in a lateral position on a Jackson table, and you have to kind of tuck them into a cocoon position and not put arm boards on and things like that. And it's a little bit of a challenge to do it, but the localization, and we put a reference frame on the spinous process in the back of the patient. And so everything has to be lined up, line of sight. And that's why I say it's a little bit of a challenge doing that, but it's actually not, once you kind of see how to do that. And that eliminates, you know, oftentimes like an hour in the operating room of localization. I mean, we put the patient in position, put a reference frame on, spin a CT scan, we're navigating, and the operation proceeds. It's done just that easily. So I think the intraoperative CT scanner is, well, to me, in my experience with, you know, just a generational change of going through several different phases of evolution, you know, going to 3D navigated CT scan, the guidance for doing these operations, total game changer. I can't imagine not doing it without intraoperative CT and navigation nowadays. It tells me where I am, what I'm doing, how far I've resected across. You know, Rod Esculian, he wrote a paper back when he was a resident at UVA about thoracoscopy. And so it's changed a lot since then. But Rod did some of the early work about localization. We used to put paper clips on the patient and all kinds of things like that and do fluoroscopy. But the CT is a total game changer. I can't work without it, really.
If I could just comment, also seeing those images brought back memories of Henry Bohlman Fellowship. But for the young guys, there are some really good pearls there, whether you're doing this open or endoscopically. And that's, you know, establish your territory, isolate the disc spaces above and below. Once you take the pedicle down, it's an eye opener because you're looking right into the canal. But then I think the most important thing that Henry contributed was leaving that posterior margin and not being in a rush to start to decompress disc, because as you do that, the cord and the dura fall down and obscure your view of the contralateral side. And then you have to retract or you have to work blind. Whereas if you leave that posterior shell, you can excavate your cavity all the way across and then much more safely fracture it down into the cavity under control without having to go digging blindly. So very basic techniques, but they translated very well now into the current generation where fortunately our tools are better and our visualization's better, and we don't have to hurt patients with a big thoracotomy as Jens mentioned.
So I'm going to patch Dr. Mo Etemadi, put in a reference for that RadLink technology that Dr. Courier pointed out. So thanks for that hint. And I'm going to put that on for all attendees also. And thank you, Mo, for sharing that.
Awesome. Well, thanks for great comments, everyone. I think we'll move on to the next article. Dr. Omar will be presenting. now talking a little bit about OPLL. So Dr. Omar, you want to kick us off?
Yeah, sure. First, I do want to thank the Seattle Science Foundation group for obviously allowing us to host again. It's a good learning experience, and we're happy to be a part of it. Let me see if I just have control of this just yet. Yeah.
Can you speak up a little bit, Adan? We have at least here in Seattle, we have a hard time hearing you right now.
Sure.
Thank you.
Give me 1 second. These slides are not moving. All right, so this first paper is a short paper. It was published in 2005 in JNS by Dr. Kato et al. Out of Kanazawa, Japan. So thoracic myelopathy due to ossification of the posterior longitudinal ligament is usually a progressive condition and responds poorly to conservative therapy, leaving surgery really as the most reliable option. So in these patients, anterior decompression and removal or floating of the ossified posterior longitudinal ligament is the most effective method of relieving pressure on the spinal cord. So performing, excuse me, I don't know what's going on here. Here. So performing an anterior spinal cord decompression is technically demanding and has been reported to cause post-operative neurological deterioration in the literature. They also do mention that despite surgical advances, favorable results are not always achieved. Because of these reasons, the authors of this paper developed a technique to remove or float the OPLL in the thoracic spine from a posterior lateral approach. They believe it was more safer than and effective than the original or conventional procedures. It also allowed for gradual decompression over time and is useful for beak-type OPLL cases. So the purpose of this study was to examine the clinical outcomes after an anterior decompression from a posterior lateral approach or beak-type OPLL in the thoracic spine, and to address the gradual spinal cord decompression caused by migration of the floated plaques after surgery. So between 2011 and 2013, 12 patients with thoracic myelopathy due to OPLL were surgically treated at their institute. 6 patients with beak-type OPLL on the thoracic spine underwent anterior decompression and instrumented fusion from a posterior lateral approach. The other 6 patients had other forms of OPLL and underwent posterior decompression and instrumented fusion. For the 6 patients with beak-type OPLL that underwent anterior decompression from a posterior lateral approach, the first 3 patients in their study had the OPLL removed, while the last 3 patients had the floating technique removed. The surgical outcomes were assessed with the Japanese Orthopedic Association score for thoracic myelopathy, which is derived from the scoring system for cervical myelopathy. For radiographic parameters, they looked at the OPLL occupying ratio, which is illustrated there on the right. They also looked at the migration distance of the floated plaques at different time points, as well as the anterior decompression ratio. For their surgical procedure, they performed a total resection of the posterior vertebral elements, laminectomy, removal of the transverse processes and pedicles to allow more space. They also took the thoracic nerves at the anterior thoracic decompression levels to improve visualization of the ossified ligament. Pedicle screw instrumentation and posterior lateral fusion using local bone was performed. And they did mention that in the floating plaque group, kyphosis correction was performed because after intraoperative ultrasound, they demonstrated that persistent spinal cord decompression was noted. So performing this maneuver sort of allowed backward movement of the spinal cord. So looking at the clinical outcomes of their procedure, they do report that all patients had at least 2 pairs of thoracic nerves that were sacrificed. However, this did not cause significant pain that required any medications. A temporary mild neurological deterioration that was transient after 1 month or so, as well as a minor dural tear occurred in 2 patients in the removal group, and no significant complications were seen in the floating group. The average recovery rate was about 52% in the removal group and 60% in the floating group. Looking at radiographic parameters, the OPLL occupying ratio in the floating group was 85% or so, which occupying a good portion of the canal. So they mostly looked at the floating group when it came to the radiographic parameters. The 3 patients that had gradual decompression of the canal with migration of the floated plaques into the bone resection of the vertebral body during decompression, as you guys can see in these images here. So this was in the 6-month period. This was about a 3-month period. And over time, the plaque would gently migrate ventrally, increasing the anterior decompression rate. And after about 12 months or so, they reported that these would go ahead and fuse. So in conclusion, 2 out of the 3 patients who underwent removal of the plaque experienced significant complications. The final recovery rate, however, was similar between the 2 groups, but no significant complications were noted in the floating groups, demonstrating that it is a safe and effective method for patients with beak-type OPLL cases. They do mention that this is the first paper to describe the migration phenomenon after the floating procedure. And this did provide additional spinal cord decompression in the postoperative period. This paper do have several limitations. Obviously, is from a single institution, and it's a very small case series with only 3 patients in the floating group. But I thought it was overall an interesting paper. And I'm just leaving it open for discussion.
Thanks, Adan. That was a great review. I know Dr. Courier's done this technique, I think, once or twice before. Do you feel like the intraoperative CT navigation helps with this, especially maybe a post-operative spin to sort of assess the adequacy of that anterior decompression from a posterior approach?
I agree entirely with Dr. Johnson that image guidance is critical to these cases, whether you're doing it thoracoscopically or mini open, retropleural, or from the back. I think it's extremely helpful. The technique that in terms of floating these huge ones, these beak-like ones, you may well have to go anteriorly. What the Japanese have learned over the years is that very frequently you don't have to do anything anteriorly. Oftentimes you can just do it posteriorly with a laminectomy and a fusion. Under contouring the rods is what Tomita and Kawazawa like to do to dekyphose the thoracic spine to improve your decompression. But one thing that Tomita described back in 1990, and Kawazawa wrote up the experience in 2008, was, and I've done this before, is in a posterior approach, put in temporary instrumentation, do your laminectomy. You do need the temporary instrumentation before you do a laminectomy, by the way, because if the spine just moves a little bit, you could get into trouble. So put in the rods and then make troughs on either side of the cord. And those troughs can be used subsequently for an anterior approach if you need to, through a mini open retropleural approach. So if you make these troughs, it makes it much easier to then float the OPLL from the front. And so that's what Tomita described, to start off in the back, putting those troughs on either side, filling those troughs with bone wax so that the troughs would stay open for a while, and then watch the patient. And if the patient does fine and gets better, you don't have to go in the front. But if you do, those troughs are there to make it easier for you. Having done that a bunch of times, not me, but Tomita and others, they found that it's rare that they had to go back in unless it was a giant OPLL like the one that you showed in that paper. And just by going posteriorly with fusion, dekyphosing, and laminectomy is effective. Chiba from Japan cautions against the dekyphosing because he feels that puts the cord at too much risk. So clearly you want to use neuromonitoring in this, and you don't want to be greedy. So in most of these series where they're dekyphosing, it's 10 degrees or less change in the alignment.
All great comments. One of the things that they mentioned in this article was sacrificing the roots. which we obviously do very routinely. But obviously, when you start to sacrifice more roots, I would be somewhat concerned about cord perfusion. Do you do anything like put an aneurysm clip or a provisional tie first and then check some serial neuromonitoring, or do you just take them?
Well, I would be happy to take them on one side, but I'd be really cautious about taking them on both sides at the same level. And, if you don't know where the artery of Adamkiewicz is, you can certainly get into trouble. And so I think a preoperative angiography may be reasonable if you're planning on taking roots bilaterally. But the temporary aneurysm clip with neuromonitoring, I know, Dr. Nasser, you've done that a number of times, and that seems to work. I believe you have.
Arjun. Yeah, either that or just a provisional tie. And it's interesting, I actually did a case just a few months ago where on the right side, somewhere in the mid-thoracic spine, I wanted to sacrifice one nerve root. Upon putting the provisional tie on, we lost 50% of the motor to the cord, and that was just a one root temporary tie. So we undid it and kind of bathed that root with some warm saline and watched it, and slowly came back. But it was on almost an immediate finding within about 5-10 minutes of putting that tie on. So, and we hadn't really done anything else to hurt the cord. So I do think it's important to just be conscientious of that, and the artery can really come in at any level, at any location. So
Arjun, can I ask Dr. Nasser a question?
Please.
So for one, we've mentioned decompression techniques, and I think very valuable points have been made. There's a breath holding moment for me every single time when I, however gently I do it, tease off a highly compressive, usually calcific disc from the cord. And that is the disimpaction time. So assuming a very atraumatic, very gentle technique, the time when that fragment goes away from the cord very frequently is associated with some cord signal changes. We assume this is reperfusion trauma. So Dr. Nasser, you obviously have worked on cord injuries and cord perfusion. What happens when we kind of disimpact a highly compromised cord to the actual cord perfusion, and what can we do to minimize the secondary neurologic trauma from that?
I think it's a great point, and I think we all get a little bit nervous, especially in the thoracic spine, because the blood supply is so tenuous to begin with. But at this point, if we're doing anything that we're going to be manipulating the cord in any way, I like to talk to the anesthesia colleagues, really try to raise their mean arterial pressure. I usually, if I haven't, at the beginning of the case, I will give a little bit of steroid preemptively at this point as well. I don't know that we have any magic cures other than being very cautious in what we're doing, but I like what Dr. Currier has mentioned in that temporary rods. If you've done any form of a destabilizing procedure as you're doing this, so you really don't have any other variables that are working against you. But this is obviously a very crucial part of the case. I like to make sure that our anesthesia colleagues are on board. If we've lost a lot of blood, want to make sure that their hemoglobin is up. So anything that you can do to improve perfusion. I don't routinely preemptively place a drain, but there's maybe some talk about diverting, CSF drain at a distant site, maybe to improve cord perfusion, but I don't do that routinely preemptively.
Okay, well, I think that sort of brings us to our end time. And I'd like to thank all the panelists, including Dr. Nasser, Dr. Currier, and everyone else on the call today. I think it was a really interesting discussion of a fairly difficult problem to treat in the spine. And so hopefully the articles today have given us a little bit more information moving forward.
Thank you for bringing this up, Arjun, and your colleagues. You have a great group, great topic, unresolved issues. For me, the OPLL discussion is an ongoing one because I think all the highlights have been made. Preserving the dura has significant advantages, and this is a high morbidity aspect of OPLL treatment. So I like Brad's idea of trying to just posteriorly decompress as much as possible, realign the spine, stabilize it well above and below the target lesions, understanding the geography of these conditions cervically and thoracic and lumbar wise also. And again, being very cognizant about the multifactorial aspects of doing these surgeries. This is not a walk in the park surgery. So thanks for raising our awareness, and we had a great discussion online also.
Yeah, thank you, everyone.
Super job.
Thanks to the Seattle Science Foundation. Great job.
Take care.
you,
Be
Brad.
safe, everyone.
Thank you very much.
Yeah, thank you.
Thank you.